All right, and like I said, airway management is a huge slideshow. There is so much information in this. Some of it, the good thing is tonight is a lot of basic information. Some stuff you will know, some stuff you will not. Um, when it comes to, we're going to talk a little bit about like acid-base arrangements and the pH scale and how our body, using the respiratory system, tries to counter that. I have like a 6-minute video that I'll play on YouTube. It's by EMT Prep. I don't use them. Our program doesn't use them. It's just a useful video that I found on YouTube that I think will help you guys out a little bit and explain it down, kind of at a more foundational level than I would be able to. So one of the biggest things that we will do as paramedics is obviously making sure that our patient maintains an open and patent airway. Pretty simple, not much to it. The only thing additionally that we can do as paramedics, obviously, is procedural wise, we have the option for intubation, whether it be oral tracheal or nasotracheal, or we have the option if we need to, such as a quick crike or a needle crike. Our assessment really, we always say ABC, ABC. We kind of begin that the second we walk in the door or walk wherever, we're going for the call. If the patient's talking to us, they're able to speak, they've probably got an open airway. That's not taking into account breathing at all. That's just, do they have an airway that is open? Do I need to worry anything about their airway patency? In regards to the respiratory system, pretty simple, right? We bring in oxygen and we breathe off carbon dioxide. Our body does this through what we call cellular respiration. So as we bring in oxygen, our body uses it as fuel for our organs, our brain, our heart, everything. That waste then comes back and we breathe out carbon dioxide. Our body does this, what, 12 to 20 times a minute, roughly. The thing is, as if we were to eliminate oxygen, the outside air, inside air, wherever you're at now, is roughly 21% oxygen, 20.9 is the exact amount, I think 20.9% oxygen. If we were to take oxygen out entirely, that's when we would become hypoxic. The problem with hypoxia is that our organs will start to shut down and our non-vital organs will start to shut down first. What I mean by non-vital is things like our liver, kidneys. Even though they're vital, our body looks at it and says, well, I need to keep my brain and my heart going. So those are the things that it tries to shunt oxygen to first and try to, shut down other organs so that they aren't using up the oxygen the brain could use. Roughly 4 to 6 minutes is how much time our brain can endure before it starts dying off without oxygen. It's really not that much time. I mean, think of a cardiac arrest situation. We're dispatched out at 2, 3 in the morning, whatever it might be. We're out the door in 2 minutes. Takes us 2 minutes to get there. If nobody was doing CPR or moving oxygen or breathing for the patient or anything like that, there's already a chance at 4 minutes that this patient has some sort of neurodeficit or a noxic brain injury just due to, lack of oxygen, lack of respiration. As paramedics, our job is a little more stressful than at the EMT level because we have to manage the airway a lot more indefinitely. This isn't just OPAs. This might not be just NPAs, Kings, iGels, LMAs, whatever you're used to using. This is us potentially isolating the airway entirely through endotracheal intubation and taking over respiration for somebody, or maybe putting them on a ventilator. A big thing that I see most often is people forget their basics. Basic techniques a lot of times will suffice. Not every patient has to be intubated. Not every patient, do we have to RSI and put down. Throughout any chapter, throughout anything within your paramedic education, do not forget your basics because we're so quick. You learn all this new knowledge as new paramedics, all these advanced techniques that we want to rush to them really quickly. Oh, I need to get an IV. I need to do this. Just focus on the basics, ABCs. That's what keeps people alive. And, reassessing our patient's condition. It brings up right there in that slideshow, continual reassessment. Yeah, that's something we should be doing, and we shouldn't have to remind ourselves. It's just something we do without thinking about it. It should just be another function when we are with our patients. Is just looking at them. Maybe we're taking another blood pressure, whatever it might be. Depending on what the patient's complaining of, I might focus a little bit more on, such as, difficulty breathing. I might listen to lung sounds first. I might not be too worried about blood pressure. I might, you know, dive a little bit more into the respiratory history. We might focus a little bit more on what medications they're on that could disrupt a respiratory function. Um, Management of the airway, and when we say appropriate airway management, it's really, again, not going as invasive as possible. It's doing what's best for your patient, and that's our ultimate goal. Is I don't care what anybody says. They want to act like they're, they want to play paragod, or like paramedics are the best thing in the world. That's fine and dandy, but ego should not get in the way of patient care. And that's something you'll hear me preach nonstop, is that our egos do not replace patient care. Our patients come first, and we should do what is best for them. And if that's something simple as bagging them, then that's what we do. If I can bag somebody and prevent from RSIing them, I absolutely will. Unless I'm on a long transfer, or long transport or something like that, and I happen to have a ventilator on the ambulance that I'm on, just because in that matter, I know that that patient is receiving the oxygen they need. I know that they're receiving the breaths they need at an exact time. But again, if it's not needed, why go so advanced so early? Start basic and then work your way up. Some things you guys will need to know. Anatomy plays a huge role when we talk about the respiratory system. Upper airway, lower airway, different parts of the upper airway, different parts of the lower airway. Let me see if I'm going to move to the next slide here. Should have yep, there we go. Our diagram of the upper airway, right? This is what starts essentially at our lips and goes down to our glottic opening, or what we call our epiglottis. So anything above that point is considered upper airway. And as you can see right here, let's see if I can draw that out for you guys. Epiglottis, pointing right here. Anything below that is considered our lower airway. Our larynx is essentially what you can feel. Well, if you, unlike me, if you've got like a skinnier neck with not so much baby fat that you haven't outgrown, but you like your Adam's apple area, right? You can feel that kind of almost bony structure midline on your trachea. What you're feeling is actually this cartilage right here, which is called your thyroid cartilage. It's a raised area that you'll actually notice protrude through the skin, and you can actually start to make out different landmarks, especially if the patient has a low percentage of body fat, such as their cricoid cartilage. These are both very hard areas. You can kind of see right there, it almost looks like plastic, as opposed to these areas up here and in between here, which almost look more um, fibrous. They look a lot softer, and that's because they are. Uh, and something to note, especially when we talk about our larynx, and this is saying that we're looking at the patient's neck. This is our trachea going down to our lungs. This area right here that I keep circling, that really soft area in there, is what's called the cricothyroid membrane. And why that's important is because that's the landmark that we go for when we have to do a needle cric, or we have to do a quick cric. We have to literally find our thyroid cartilage and our cricoid cartilage and find the soft spot between them. That soft spot is what is called our cricothyroid membrane, and that is what we are shooting for when we are looking at possibly needle cracking somebody. Now, am I saying you have to memorize every single thing on these diagrams? No, I'm not saying that at all. Just know some of the basic structures that come with our upper airway. Our lower airway is a little bit easier. Upper has a lot of components to it. You have obviously your nasopharynx, which is going to be referring to your like nose and then nasal sinuses, your oropharynx, which they do connect, and then your laryngopharynx, which is going to be a little bit farther down. If it makes sense, laryngopharynx, laryngoscope, that's what we use to intubate somebody. So when we go through these and you hear about rings of the trachea, you can honestly on yourself feel your trachea, and you can feel as you go down, you can feel these cricoid rings, these hard bumps. It almost literally feels like a ring, right? Those are what's referred to as our cricoid ring. Now, in between these is soft tissue. So in the event that it could be trauma, it could be, um, somebody's maybe fallen and hitting their neck on a desk or something like that. That's what we're concerned about, is those areas right there potentially getting a tear, or a tracheal tear or whatever it might be, because at that point we have a closed loop system, which is now an open loop system. And again, our cricoid thyroid membrane is that really soft membrane in between our cricoid cartilage and our thyroid cartilage. Let me see if I can pull that picture back up. Let me erase all this stuff so it makes a little bit more sense. Right there, that really soft area right in the center. Now, it's not very easy to find on some people, and we'll have the chance during labs. I'll bring up an airway model. You can honestly, even on our SimMan, on our airway mannequins, everything, you can actually palpate our cricothyroid membrane, look for that soft spot. And when we start to get into trauma and a little more advanced airway management, we will be doing things such as needle crikes. All right, we have what is called our glottis. Now, there's epiglottis and then there's glottis, right? Epi, usually when we say epi, it refers to the outer part. Anytime you see epi in anatomy, it usually means outer. So if you can see right here, it's pointing to this outer layer. What you'll notice here, and this is very important because it'll stick with you for the rest of your career, is these two white fibrous bands. Why those are important is those are your vocal cords, right? As somebody speaks, those vocal cords close, they open. Um, and I've got another video that I can show you guys that actually helps out a lot with anatomy. That's what we look for when we're going to intubate somebody. When we're in there, we have the laryngoscope, we have the light. That is the landmark that we are looking for, because we are going to pass our tube right in between the vocal cords, is our goal. Right past the vocal cords is our trachea. You can kind of see outlines of our rings down here, which will lead down to our lungs. And again, I have a scope going down through the glottic opening. An anesthesiologist does it, and it's actually a heck of a video. And I'll actually pull it up here shortly. Here within the next couple slides, I'll stop and pull it up. Now, our trachea, very important. It's our windpipe, right? It's what takes upper airway down into lower airway. It brings air from the outside down into our lungs. Now, if I was going to draw this out, I've got my trachea, I've got my rings, my windpipe, and it's going to branch off and go in different directions. So we're going to have a left and a right side, which is obviously our lungs. This being our right lung, this being our left. This area here, right where our trachea splits, is what is called a carina. And I might be getting ahead of myself, but if we intubate somebody on our right side is a lot easier for the tube to just go straight down, as opposed to the left side curves over a little bit. So there's a chance if we push our ET tube too far down when we're intubating, that you can actually intubate just the right lung, when really we want that ET tube to sit right or out there so that we're ventilating both lungs. And I'm going to pull up that video real quick that'll actually bring this together a little bit. If your mind's blown, I promise, or if you feel lost, it's fine. That's normal. I promise it's normal. Can you guys hear that by chance, the video when it plays?
Yes.
Okay, perfect.
You can hear it.
I want you to pay attention to the anatomy and the structures that we just kind of went over in this diagram and what he shows you with this video.
I would like this video to throw some light on awake oral endotracheal intubation. There are many situations where an awake intubation is a useful technique or perhaps even a standard of care. For example, a patient with angioedema affecting the upper airway may benefit from an intubation performed awake. Administering a syringe of propofol or etomidate will cause unconsciousness and may aggravate airway obstruction and certainly leave the airway unprotected. Administering muscle relaxant will stop spontaneous breathing, and as a practicing anesthesiologist, I always consider keeping someone awake and breathing as a priority and a possible plan A.
This guy's insane, by the way.
At the cricothyroid membrane, everyone feel there. So the top of your neck, the top bump is the thyroid cartilage. That's the notch. And then when you come down a little bit, you're going to, before you get to the cricoid cartilage, you're going to get to the cricothyroid membrane. Nothing's there. I do it every year. So, alcohol swab. Ready? Needle goes in. We just sit there for a minute, and, well, 2 seconds. He'll withdraw bubbles slowly. And then just get the 3 cc's in and pull out. Perfect. Yeah, because you want to spread it around the trachea. The next thing we're going to do is I have 5 more cc's of lidocaine, and this will go on the fibroscope. And this way we can spray structures as we see them.
So as this enters his mouth, I want you to look at the structures that he's looking at, and you will see those white fibrous bands, the vocal cords, clear as day, and that's our hope when we're looking at intubating somebody. Let's put it in perspective, a King LT or an LMA or an iGel sits right above those vocal cords. Okay, you can see right down in there. You can see his epiglottis, that outer structure, and then down in there you can see those white bands, and they open and close as he's humming, as he's talking, whatever it is. Watch those bands open and close.
Okay, so we saw the cords and sprayed them. And we'll get started again.
So he went past the vocal cords, and now we're traveling down the trachea. You can see the rings of the trachea as we go down. And you can see right there that carina where we branch off into our right and left lungs. You can see the left side is curved more as to where the right side is literally a straight shot down. Again, that guy's insane. I don't recommend doing that. I wouldn't do it, to be honest. But it's a good representation that shows some of the anatomy that we are looking for when it comes to innovation. And some of this will make a little bit more sense when we get into lab and start innovating mannequins and looking for these landmarks, and kind of the process of doing that. So again, don't feel like I expect you to know all this information. When it comes to, let's see, yeah, ventilation. Ventilation is the actual act of moving air in and out, as to where respiration is the exchange of carbon dioxide and oxygen. Huge difference. Ventilation is the mechanical process. Respiration is the, we'll just call it chemical process. Do not get those too confused, because it can lead you kind of astray a little bit. Our body needs a constant supply of oxygen to function. We need a constant supply of oxygen. We need a constant supply of glucose. Those are the two main fuels for the body. So, little pop quiz. We have our diaphragm, right? It sits right below our chest cavity. When I breathe in, why does my diaphragm lower? Like, why does my diaphragm literally lower from my upper chest down when I'm exhaling?
It changes the pressure to draw air in.
Yeah, it's changing pressure to draw air in. That's absolutely right, through negative pressure. So think of it this way. If I had like a syringe, like a 10 ml syringe, 5 ml syringe, whatever syringe it is, if I put my finger over the top and I pull down on the plunger, what happens? My finger wants to get stuck because the air, the negative pressure. That's exactly how our body works with air. Our diaphragm lowers, causing air to be forced in through negative pressure. Then when we need to breathe out, our diaphragm raises and pushes the air out. This goes without saying. Oxygenation, obviously the process of bringing oxygen carrying molecules into hemoglobin molecules. Hemoglobin is what carries oxygen. So when we start to talk about like pulse oximetry, pulse ox only measures the amount of hemoglobin that is saturated. Hemoglobin, all it does is carry chemicals, right? Now, the problem with that is it doesn't measure the amount that's saturated with oxygen, it just measures the amount that is saturated. So somebody that has maybe, I don't know, hydrogen cyanide poisoning could show a pulse ox of 100%. That doesn't mean that's 100% oxygen. That just means that their hemoglobin is 100% saturated. So pulse ox can be kind of a liar, if you will. I like using pulse ox, but at the same point, even now in the Iowa scope of practice, they allow EMTs to do capnometry. That tells more of a story than pulse ox, and it takes a pretty extended period of time before we start to see pulse ox drop. We get so worried putting somebody in a cardiac monitor, or on a pulse ox on our monitors and watching their pulse ox. It's going to be a while before you start to notice that patient's out. If you're just paying attention to that pulse ox, as to where like capnography or end tidal is simultaneous. The second they stop breathing, you'll see numbers start to change. And again, this is something we'll demonstrate in the lab, and I actually demonstrated on myself just to show you guys. We have what's called internal and external respiration. So external respiration is as we bring air into our lungs. At the bottom of our lungs, we have these, what looks like, honestly, grape clusters. And these grape clusters are called alveoli. They're like little bubbles, if you will. And their job is to slowly open and close and open and close. Well, when they open, they let carbon dioxide out and they bring oxygen in, they close, and then internal respiration takes place. And what's happening there is that they're taking that oxygen and introducing it into the bloodstream so that it can be carried throughout the body. And our body just continually does this nonstop over and over and over again. So, just for a little reference, what's a sound that we would hear if we're listening to lung sounds? Think of maybe a CHF patient. What sound are we most likely going to hear? Anybody? It sounds like Rice Krispie treats if you were to crush them up in your hand. Referring to as crackles. I mean, literally, you'll hear like bubbles, essentially. What's happening when you're hearing those bubbles is that those alveoli are underwater. They're under fluid because of CHF or whatever it might be. So that popping, those crackle noises you're hearing are those alveoli, those little grape clusters popping open. Hence why we put somebody on CPAP. When we put them on CPAP, it pushes the fluid away from it and they can open freely. They don't have to pop open underwater. Now, disruption of any one of these processes might not be an immediate thing that you are going to recognize unless you're monitoring something such as end tidal. I mean, you're going to notice pretty quickly if somebody stops breathing, but you're not going to notice if their body stops, producing carbon dioxide and bringing in oxygen. It's going to take a little bit of time before you start to notice that. The biggest thing that we can watch out for on our patients is making sure that they have good oxygenation status, that they have a good ventilation status, and that they have a patent airway. Lung sounds are huge when you're going through paramedic school and becoming really good at lung sounds. Not just I listened bilaterally, they were clear. More. We're gonna spend a lot of time on lung sounds. I kind of went over this a little bit, but it shows you how much time can lapse before we start to see changes within the body due to lack of oxygen, due to hypoxia. So 0 to 1 minutes, we're starting to see the heart become a little irritable. We're starting to see the heart become pissed off, to be honest. And what happens is the heart needs oxygen to pump just like everything else. If it doesn't get that oxygen, it starts becoming injured. Around the 4 minute mark, we start to see brain damage. Oh, brain damage not likely. Okay, but 4 to 6 minutes brain damage possible. So 4 minutes where we can begin to see brain damage. 6 to 10 brain damage very likely. More than 10 minutes irreversible brain damage. If you've ever been on, I've been on a handful of them. A cardiac arrest where you got the person back, but it was determined that they were brain dead. It's generally due to hypoxia or a prolonged state of hypoxia in which their brain just function left. They just have no functionality of the cells in their brain to be able to conduct any sort of procedures or life-thriving homeostasis. That's the word I was looking for. Hypoxia should not be a new term to us. This is something we know as EMTs. This is a lack of hypoxic. Their lips start to turn blue. Maybe they get a little bit pale in color. Maybe hypothermic, whatever it might be. If somebody early on starts becoming hypoxic, some of the things that we'll start to patient will start to become irritable. Heart rate will start to increase a little bit because as you become anxious, your heart rate goes up, and then obviously anxiety. Think of, driving up the mountain or something like that, especially if you're not used to higher altitudes where oxygen is lower. Yeah, you have the potential to run into some of these things. Sitting as you are now, even if you're just driving up, some of the late signs that we can see, mental status changes. Patients get pretty violent if they're hypoxic because their brain is starving. Weak pulse because their heart is, irritable, slow down. And then cyanosis. At the point that we start to see cyanosis in a patient, that's pretty late. Cyanosis doesn't just come on immediately. You don't just start to see the bluish lips, the pale color. It becomes cyanotic. Some of the things, again, you'll see first are patients starting to get concerned about their well-being, or, they can't, feel like they can't breathe. Maybe they're worked up. Those are pretty early signs that somebody could be hypoxic. Things that can affect ventilation, and this should be nothing new to us either, right? Infection. What did we just go through for the last 2 years, right? We lived and breathed infectious disease when in regards to COVID. That was a infection. Think of RSV. That's an infection. That impairs the ventilation process, right? Allergic reactions, not just a standard allergic reaction, more of like an anaphylactic, a severe allergic reaction. How does that affect ventilation? Well, when somebody's airway starts to swell up and it starts to close, that's limiting the amount of air that we're bringing in. So yeah, it is going to affect ventilation. And then obviously unresponsiveness. Does this patient have the ability to maintain their own airway? If they can't, then again, we need to find the best procedure for our patient to maintain that airway. And it could be something as simple as an OPA or an NPA. Some other factors, I mean, think of medications, right? Certain meds that people are on, especially if it's a med they haven't been on before. Think of, you guys have all heard the term know somebody. If I give somebody too much fentanyl, too much Versed, I could potentially render them unresponsive to the point they're not breathing. Trauma is another big one, especially talk about like spinal cord injuries. That's always a concern with car accidents or somebody that has hit their head on the steering wheel or the windshield. Is they have any. Generally, if it's due to trauma spinal cord, about the level of T3 or T4, which I don't feel like, if you don't know that, don't freak out. Thoracic 3 or thoracic 4 vertebrae is where our body controls ventilation. So if there was a fracture around, there's a potential that our patient can't breathe on their own. They would have to have trauma to the chest wall. Absolutely. Collapsed lung, maybe a potential for a pneumothorax, where we are only getting one side of the thoracic cavity that is truly working. And that could be due to an open injury or it could be due to a closed injury. Listening lung sounds is super important. Breathing bilaterally, especially if we have a penetrating trauma to the chest, lung sounds should be one of the first things we're going for to make sure that there is ventilation. If not, what happens is that pressure builds up over time, can actually cause our patient's blood pressure to drop. Flail segments, multiple ribs of in the same area, 2 to 3 ribs that are broken right next to each other. That's what we call a flail segment or a flail chest. All things that can affect ventilation. Hypoventilation, obviously anything hypo is below, hyper is above. So hypoventilation is when our patient isn't breathing adequately, right? Carbon dioxide production exceeds elimination. This is when we will start to see a buildup of carbon dioxide in our patients. If we were to put somebody on end-tidal monitoring or capnometry, we're just looking at the numbers here, not a graph. The normal numbers that we're looking for carbon dioxide exhaled is 35 to 45. We want to see them in that range between 35 and 45. So in the case of hypoventilation, patient has a buildup of carbon dioxide, that number is going to exceed 45. So maybe this patient's at 55, 60. That could be a red flag to you that maybe this patient isn't breathing adequately. Now, on the other hand, we have hyperventilation. And we'll see this a lot of times with patients having severe anxiety attacks. They'll feel like their arms and legs are going numb, or their arms and legs are starting to tingle. That's what we call carpopedal spasms. The reason that their arms and legs are tingling is because they've eliminated a ton of carbon dioxide and their body's relying on oxygen right now. Now, if we think of those numbers again, 35 to 45, if I'm breathing off a ton of carbon dioxide, my number is going to be lower than 35. So if I have a number that's higher than 45, I'm holding on to too much. Lower than 35, I'm breathing too much off. Why that could also play a role is a patient that's unresponsive that we are bagging. I pay attention to end-tidal something fierce because if I have a patient that is sitting at 56, 57, I might have to bag them a little bit faster to get that number down. As opposed to if I have a patient that's sitting at 25, I might slow down my ventilations until I get them up in that area and then continue. Anytime looking at that table that you see like PA CO2 or like PaO2, What it's referring to is partial pressure of our arteries. So PaO2, that could be the amount of oxygen within our arteries. PaCO2, the amount of CO2 within our arteries. We don't necessarily have them around here, obviously, but higher altitudes, you're going to see people, the oxygen level saturation is going to drop. Pressure is going to actually decrease, almost like, excuse me, almost like they're starving for oxygen is what it's going to feel like. They might start to develop a headache. Another thing is closed environments, especially if it's a confined space of some sort and there is no way to get fresh oxygen into there. That's always a concern because at some point we're going to run the oxygen out. Think of, if I was to light a candle, right? And I put this candle in a box and I seal the box up as tight as it can go. That candle is only going to burn as long as there is oxygen in there. The second I take the oxygen away, the candle puts itself out. Um, this kind of goes back to what I was saying about CHF and having fluid in the lungs. So anytime there's fluid, it's obviously creating pressure. That pressure pushes on our alveoli, not allowing it to function. It cannot open and close like it normally would. What happens is we have to end up putting these people on CPAP to kind of push that fluid away. Anytime we refer to pulmonary edema, it could be a medical condition. It could be an inhaled irritant, such as a chemical that had caused the fluid around the alveoli. Could be an allergen. People being outside, a severe allergic reaction. Could be a drowning. There's all these different types of things that could play a factor into this. I had mentioned earlier, two things our body needs. We need oxygen and we need glucose. Obviously, hypo meaning lower, so hypoglycemia, lower level of blood glucose levels. Infection, again, hormonal imbalances, such as ketoacidosis. Let's see, if you guys remember back to EMT, somebody that has is unresponsive, has a really high blood sugar, they have like a fruity smell to their breath. What you're smelling is ketones, and that's due to the massive amount of excess blood glucose that they have, or glucose that they have in their blood. What happens during that is their body tries to compensate. We have those patients in hyperglycemia can experience what's called Kussmaul respirations. And what Kussmaul respirations are is the body trying to blow off that excess, essentially sugar. That's why patients with Kussmaul respirations breathe really deep, slow, but really deep because their body is trying to blow off. I bet if you put those people on end-tidal, they'd probably be sitting in 60s, 70s, and their body is naturally trying to blow off that carbon dioxide without them having to think about it. Obviously, inadequate perfusion can affect oxygen being carried throughout the body. If I was to sustain some sort of trauma to where blood is no longer circulating and I've taken a closed loop circuit and made an open loop circuit, yeah, there's potential that I am now losing oxygen carrying components such as hemoglobin. That's always a concern, especially when we get into like our trauma chapters, is patients that have severe hemorrhaging and are going into shock. You're going to start to see pulse ox drop pretty dramatically in these people because they're losing the ability to carry oxygen. It's not that they're losing the ability to take in oxygen, they're just losing the ability to carry it because they're losing blood. Um, Referring to shock, oxygen not delivered efficiently. So there's a couple different types of shock that come into mind. We have hemorrhagic shock, which is obviously bleeding out, and we have vasodilatory shock. And that could be something such as an anaphylactic reaction. That could be anything that is going to open up blood vessels. when we say the word vasodilate, that means opening up some sort of blood vessel, whether it could be an artery, whether it be a vein, whatever it might be. Vasodilation is opening up, as the word vasoconstriction is closing. So vaso meaning vein, constriction, or I say vessel. Vasodilation, vessel dilating. All right, before I jump into acid-base balance, I'm going to give you guys like a 10-minute break because this part can get a little, and I know your brains might be kind of scrambled already. I'm going to give you guys till, we'll say 6:55. We're going to come back. I'm going to talk a little bit about acid-base balance, and then we'll play a video for you guys. This is the part that people will kind of get the most confused on. Don't freak out. It's not a big deal. We're going to spend a lot of time over this over the next year. So take 6:55, be back here, and we'll keep going through these slides.